go.
All right, let's do it. So thank you all for joining this this particular breakout. My name is Yasir Tarabichi. I'm a physician informaticist and director of clinical research informatics at MetroHealth. So in a nutshell, data obsessed, and I'm very curious how this discussion is going to go. You got the opportunity to hear from Dr. Duran in the four slides in 4 minutes. So I think the context is relatively clear. I'm just going to go ahead and open up the floor for first shot questions here. Chat. I mean, I have plenty if you guys want to hear from me, but I don't think you're gonna hear from me all day. I'll start with some of the structured questions that we kind of thought about ahead of time. Question number one: what are the greatest challenges for ensuring that data sets are both inclusive and representative of minority populations?
I can give one answer to get the discussion started. Part of the biggest challenge that we have is missing data. And one of the reasons that the data is missing is two-pronged, or there's actually two-pronged reasons. One, people collecting the data often feel intrusive or embarrassed or challenged to collect the data. So they don't know to ask, or they feel uncomfortable asking what race and ethnicity you are, or what age you are. That's one part of it. The second part of it is the participants' resistance to tell you. And if there is resistance to tell you, then if we don't collect this information, there's a challenge for us to do research or anything in data science, then we have no way to do data parity or population parity. In other words, we don't know how to fix the healthcare for one population group over another population group that has different gene variances or different disease risk. So collecting this kind of demographic data is really critical. Giving this demographic data when you're asked for it is also critical.
Sarah's, feel free to chime in. I could just read out your comment, or folks could take a look at it too.
Yes, thanks. Can you hear me?
Yeah, perfect.
Yeah, I found I'm at UW-Madison, we have a CTSA and have for many years. We have a rapidly evolving informatics infrastructure. There's been a lot of turnover in leadership and, of course, the impacts of healthcare delivery system, finances, you name it, all of it. But I really love the grounding of this conversation with sort of at that very ground level of where some data just isn't necessarily even known or recognized for its missingness. And I just wanted to comment, as a person trained as a consumer scientist and a political scientist sitting in research administration, there is just such a fluency gap when people are gathered in a room lacking translators. And, I totally appreciate your comment about being data obsessed, and I love that energy and that desire to be a part of a team contributing to change. But this is probably the biggest issue I have faced as a research administrative leader, is trying to interpret sort of what's going on in some of these spaces and connecting it to the public health equity landscape. So I just want to offer that. I don't have an absolute solution. I have found great support with informaticians who are also instructors, and so sort of natural teachers with a willingness to sort of explore this with me and others. But it hurts my heart to know there's such energy and knowledge that needs a bit of curating and collectivism. So I'll stop there.
It's a great comment. So, being in the informatics world, we're at the front of that. And I think that there's a lot of assumptions made about the quality of the data that goes into the system as far as the electronic health record goes. There's publications that refer to race and ethnicity as kind of, patient reported, but they're not patient reported. They're, to Dr. Duran's point, somebody was at a desk and an assumption may have been made. I've even heard things that, I'm ashamed to bring up, but there are people that have brought up maybe issues with what they think are data disparities or concerns in data, accuracy based on how the name matches up to a race or ethnicity entered in the EHR. And that doesn't even start to get to the issue of, multiracial ethnic individuals and how that's captured in the electronic health record. So it's a mess. And I think the problem is there's a lot of momentum for where we are, where we've been, and trying to turn that energy around and just kind of blow it all up and say, let's start over. We don't know until you actually tell us, which group, I guess, which identity you want to attribute yourself to. I think that's the challenge that we have today. And you brought up education, which is awesome. The people that are putting this data in, they are not receiving that kind of training, that kind of sensitivity training. And that's something that if you think about larger institutions, to bring everybody together and get them on on that wagon, like that's a lot of effort. Not that we're not doing that, right? There's a lot of that going on today, but it just touches so much of their workflows and processes and intake processes that, it's hard to capture it all. And then it's hard to adjudicate it on the back end, right? So how do you know that the data is good? It's just assumptions on assumptions.
Let's not just limit it to electronic health records, because it's pervasive across every national data set, every study that is done, even like the CTSAs or anything. It's prevalent everywhere data and research is collected.
Yeah. And I think it gets a lot more, so you start with identity, which is already personal and sensitive. And then this kind of jumps into the issue of documenting and identifying social determinants of health. And then that becomes maybe I'm simplifying, but in my mind, that seems to always been it becomes more personal, right? It's the way that I've read it. Whenever I've spoken with patients or community members about this, I don't know what your guys' feeling about that is. Dr. Duran, feel free to jump in.
So the social determinants of health in the electronic health records have no systematic way to collect them. Sure. So in the electronic records, it's done by narrative. And so in order to tease anything out about social determinants of health, and we know that it accounts for 40% of your health outcomes, you have to use like a natural language processing in order to even pull any of that out. So having no systematic way to collect it, it even makes social determinants of health more vulnerable and worse than collecting race and ethnicity, because at least most places at least follow an OMB standard of race and ethnic data collection, but there's nothing for social determinants of health. The other aspect of that is that it is often challenging for a physician to ask the question, or any care provider, because it also, the person responding is also hypersensitive, because they could be living in their car. So they're not going to tell you that because they know that their children will be taken away. So there's a lot of vulnerability around the social determinants of health and the risk they put themselves in portraying that information to any healthcare system or any teacher or any researcher.
Hi, my name is Marissa McGinley. I'm a neurologist at Cleveland Clinic. I have a slightly different sort of, I guess, problem or question to get people's thoughts on. And so, I mean, I am a neurologist, and then I specialize in multiple sclerosis, which is like not the most prevalent disease, right? And so I'm dependent on sort of thinking about the disease across the country and trying to think about data sources, right, to combine data to understand questions more broadly outside of like our microcosm. And so things like race, ethnicity, gender, obviously, as you've already mentioned, very important for us tackling health disparities. But then when we've tried to think about those other social determinants of health that really are location based, and, you know, obviously within our, you know, electronic record, we can get address level data, right, and really start to mine large data sources to understand those community characteristics. But I've really struggled, and I am a complete novice in this area of health disparities, really just starting, really struggled with how we expand data sets outside of individual institutions to get that kind of more granular data, because we have run into so many data sharing issues. I mean, I run into data sharing issues even between Cleveland Clinic and Case Western if I want to like share things. And so I don't know if you, and I love the resources that you shared in your 4x4, and obviously we'll delve into those, but just have thoughts about how we move towards larger data sets that obviously protect our patients, but we do start to get a richer understanding of those social determinants of health that, you know, I think are just, there's a lot of barriers right now that I've experienced. So I just love to hear your thoughts.
So one of the things I would suggest, and all of you who get federal funding in any form of federal funding, that you start building into your staff data management and data scientists, because you can go across those two platforms of the two universities, but you have to map the data. But if you don't write that into your grants and into your proposals, you don't have the workforce to actually make that happen. And it's challenging because without a common currency, you know, common data elements, the mapping is very difficult. But one thing that I would strongly suggest, and I did a whole talk on this, about how to work that into your proposals and not miss that part of it, so that you can create those linked systems. So that's one way. Another way is to, as you're looking at what is important in your area, one of the things that happens with social determinants of health, we actually don't know which ones are the most relevant. So we collect everything. And sometimes that's too burdensome and it's too risky. So in your local areas or your specific disease or your specific issue, it might be advisable to really look at which social determinants of health make a difference and only collect those parts to reduce the burden.
Very interesting, and so much to unpack there. I think that, you know, there's going to be another discussion inevitably about individual social determinants of health and area-based assessments of social determinants of health, which you can dive into.
But it's also your disease and disorder.
Yes.
Whatever you're working on, because it's different.
Absolutely. And I'm going to go ahead and make a plug here. So we at Metro do collect structured SDOH beyond the EPIC standard. So we've added a couple of other items, one of which I think is connectivity. And we do try to do that intake form on everybody that comes into a primary care appointment. We've even gone ahead and expanded it to the inpatient setting. But to Dr. Duran's point, I mean, it's a lot of data that you're collecting. It's very personal data. And frankly, the concern that I have, it's not always actionable data. I mean, we have a couple of connectors where we go, well, you have food insecurity. Well, here's a referral to Unite Us, and let's see if we can get you some help there. But, you know, some of it, it's like, well, clinicians are struggling with this, right? Because, okay, well, I don't need a zip code. I know I can just look at someone's address, or I know where they live, and I get a sense for they're going to have issues, structural racism, access to things that would alleviate some of these disparities. If you don't arm them with a tool that actually helps them manage or assess or handle that, or alleviate that, I should say is a better word, you're going to end up just asking questions that are very probing, very personal. And then you feel like, well, you know, that stinks. And I can believe, and most physicians do, that this absolutely, negatively impacts health. But now what can I do about it? Well, here's a referral to social worker. Well, get in line, right? So that's an interesting point. I would say cross-institutional mapping. We have a couple of initiatives between the clinic and sorry to get a little hyper-focused now to the Cleveland area, but we do some data sharing across the board there. I think Jared Dalton is your contact at the Cleveland Clinic. Jared is awesome. It's what he does. And then I'm going to zoom out really big picture. And I'm going to say that Epic does have a big collaboration for data called Cosmos. And they've mapped social determinants of health, at least their standard questionnaires, onto the platform. And that goes, probably to the next question, the next thing we want to discuss, the difference really between individual, actually asking somebody what their struggles are versus area-based and assumed or approximated. I'm gonna stop talking, but I would love to hear from other folks about, how they feel about the space. Yep, gravity. Dr. Duran can please tell us about gravity.
Yeah, so Gravity is a nonprofit actually that was developed to standardize social determinants of health. And they've worked at, so part of the reason that it's so difficult to go across data sets is because semantics means something very different, right? So the best example I give of this is if you ask a white person raised in America, are you feeling a little blue today? They kind of know that are you feeling depressed? But you can't ask that same question. It's not translatable into Spanish. There's no way of saying, are you feeling a little blue today? And so there's semantic differences that happen. So Gravity has worked hard at getting a standardized definition as well as codes. So that is another very important part. They use link codes, FHIR 7, so that they can, in data sets, be able to link by the code, not necessarily by the label. So if anyone wants to use standardized social determinants of health, this is the place to get them. And the one I presented today too, the Phoenix Toolkit.
I incidentally had all these things open, so I'm just going to go ahead and share those links. Any other pivots in the conversation? We have, I think, 20 minutes.
But one of the things I would like to hear from you all, because, there's parts of my job, I set in a position that I can influence some changes. So what are the challenges that you guys have in collecting social determinants health data or minority data or gender data? And for those of you who are not in the know, two things are emerging. One is they're revising the standards of race and ethnicity so that Hispanic is part of the whole list and not a separate question, and adding MENA, which is Middle Eastern, Northern Africa, part of the racial groups. That's up for discussion now. So if you want to weigh in, you can go to the census website and respond. And the other thing that is emerging is a whole set of questions on how to collect SOGI data, which is sexual gender minority data, about sex, gender, and sexual orientation. So this is going to also create major changes in all the major data sets. The question is what triggered the change? It's actually been coded, or this research has been done clear back almost 5 years before 2020 census went out. It was actually supposed to be put into the 2020 census, but the administration at time stopped it. What the problem is that oftentimes for those of us who are Hispanic, and I will confess that I do this myself, that and I couldn't even do the poll because I couldn't skip race, because I consider my race Hispanic. I'm not white, I'm not Black, I'm not Asian, I'm not Native American. So that was the feeling. And so oftentimes, because of that category was left out or it was skipped, they did a whole bunch of focus groups and all kinds of stuff to put it in as a racial group itself. So the question says race and ethnicity. So if for those of you who are on the call, please tell me what the challenges are for you in collecting racial and ethnic data. Because here's the other issue with data collection. You know, we're moving into such a state of using AI to diagnose, to treat, to manage payer systems in healthcare. Everything is turning into AI. That AI is based upon the current data. So if race and ethnicity is not part of that data, what happens is it gets left out. So for instance, probably the one most people know about is genomic data. 80% of the genomic data are white people. And so when they do these great precision medicine and variances based upon your genome, it doesn't apply for all the other racial and ethnic groups. And it's not their fault because the data doesn't have racial and ethnic data in it. So we really have to make an effort to get this included so that we can be part of the solutions. So in your own research, how difficult is this? And what do you think the barriers are that could be rectified?
I guess I'm not sure. So I will say race ethnicity, at least in, yes, or maybe you had the same feeling, but at least for us at Cleveland Clinic, I feel like we do a pretty good job with those too. We also do, at least in my disease state, we have a separate patient reported discrete data entry form too that our patients do on like during their like intake process, so that like they also have the opportunity to specifically, to get to your point, specifically pick too. It's not just at like the front desk situation. So we've tried to add layers of discrete data entry that are, you know, employees that are entering it, and then also patient reported, so that it is truly patients choosing responses. So I think that just to my point earlier is I think race ethnicity is it's not perfect, but I feel like those, if anything, are the most straightforward. It's really when we get into the, I guess, also to your point of like what else, what matters, what should we put energy on really collecting consistently for other social determinants of health. I think that is where it gets really tricky of what else are we collecting consistently, and how do we get that data reliably within our systems to then have in those larger data sets.
I'm gonna echo that and say, at least from, you know, the clinical research perspective, we assume that the data of the EHR is the gold standard. So we may not actually ask again about race and ethnicity for research if we could just quote unquote, you know, fill it in from the chart. So source ground truth is essential. And I'm not totally sure again, I think that we talked about this at the outset, right? That is the challenge. We need to identify these new categorizations, and we need to basically force a reassessment retrospectively. I am not a fan of using, you know, NLP, for instance, to try to extract, assume, or even area-based information, like, or Jaleesa brought this up, right? Like family history. I mean, how do I know? I mean, what is right? How do I know who's right? How do I know who to base it on? I think we just have to ask patients with the correct standard.
Yeah, and I think that when you're doing the research part of it, that you should ask the question and not just take it from the electronic health record, because it's also a way to revalidate whether that electronic health record is right or not.
Sure.
So
I just know that
that's
anybody
a simple
mechanism
practice.
to bring
That's a
it back
simple
in.
practice that can change.
Agreed. I don't think people are thinking about how you bring it back in, right? So research data collected in parallel to an EHR doesn't often inform the EHR. It becomes siloed. It should. I mean, it really actually probably that's one way to do it, frankly. Standard practice is if you're asking a patient and there's a conflict between the EHR documented race, ethnicity, and their or race, I guess, going forward, and their stated, that should be adjusted.
And I'm going to go out on a limb on this because somebody put a quote, I think it was Giselle, put a question in about family history. I am not an advocate that race and ethnicity is a social construct. I know that your color of your skin, no matter where you're at, no matter what country you are, the lighter you're treated better, the darker you're treated worse. I get that part of it as a social construct. But another part of this, and why to me it's so important to collect race and ethnicity, is that we also know that there are biological disease and disorders that are prevalent in different racial and ethnic groups. Warfarin is not metabolized for strokes like it is in African Americans, like it is in whites. We know that these kinds of things happen on a biological basis. And I think if we can move away from this idea or embrace the idea that even though race and ethnicity may have a social construct to it, there are also biological reasons to collect this data so that we can better treat every single patient according to their risk factors. So colorectal cancer, we know, looks different in African-American males than it does in white males. We know that more African-American women have triple negative breast cancer, more white women have HER2 breast cancer. If we don't collect this racial and ethnic data, we cannot treat them according to their disease and disorder likelihood. So everywhere I go, I try to get people to try to think beyond the idea that it's only a social construct, because that is what stops people from reporting it, because they think, oh, it's just racism or it's discrimination. And it's not. There is a biology to each of us based on our ancestry. And that ancestry is linked to your phenotype of what you look like.
There's lots of different ways to classify people, and I think it's helpful to think about when it's helpful to put people in which box. And I'm not sure that for treating people that using a race category for the type of examples you just gave is often the best way. I think knowing them as people, knowing them as other ways is often helpful. And I think one of the problems that we have in the data collection that we've been talking about is lack of trust. And I think people have justified concerns about the trustworthiness of the systems into which the data are being collected. It's hard enough to develop that trust, to be trustworthy, and to develop that trust on a one-on-one basis over time. Much more difficult when then those data go into what looks to the persons who's being asked to give this data a black box, and they have personal examples as well as larger examples of when those data have been used against them. So I think we have to think about when these classifications are helpful, because it's easy to put people into different boxes. And of course, you could classify people in lots of different ways and find variability. But when is it helpful, and when is it useful, and when is it potentially harmful, particularly when the data get aggregated at a larger level in systems and then society that has a long history of using those data against people.
And you sort of just made my point, Kurt, that, it's when we take that it's just a social construct and we think of it as a a variable, a label that will discriminate against us, you have the resistance. And I encourage people to move past that part of it. Although I'm not saying that doesn't exist, but there is so much evidence that a person's health is linked to their race and ethnicity. And it's also linked to their ancestry, which is a proxy for each other.
Yeah, in an ideal universe, you could extricate for instance, the genetic polymorphisms that, increase your metabolism for a drug from the shared experience of a, darker skin color, right? Like that's, again, perfect universe. You could say this is a more complex characterization of an individual. And I think I'm kind of in between. I agree with Kurt to some degree. I mean, yes, there's biology there, but as soon as you put somebody in a category, I think that comes with implications. And maybe a good springing board here is AI modeling. You suggested it. So if you introduce a racial variable in an AI model, and obviously it's misuse, but let's say somebody predicts your risk of survival with an organ transplant, and race is historically, or even just, area-based social determinants of health associated with a poor outcome for an organ. The model will say giving this organ to somebody from this neighborhood or from that, racial origin will have a worse outcome, right, than somebody from the opposite end of the spectrum. And so
I'm glad you picked kidney, because actually African Americans need kidney more than anyone. So I am being a little bit controversial in bringing this up. I mean, obviously, if you're using a model like this, it's not an equitable model. I mean, there's enough examples that I say in the literature for AI gone wrong, but I think that is the concern when you do sweeping labeling like this, and that is the fear, right? So if you're a patient who's coming in for an assessment, you don't want to tell somebody where you live or where you're from, because if that's going to impact, especially in a zero-sum game like organ transplantation, going to impact your prospects, you're better off withholding that. And I think that gets to the trust issue that we brought up at the outset. I don't have a solution. I'm just saying that this is the messiness of the space that we're seeking to improve upon. And it's also why the information is not reported and collected. And if we can't move past this mindset, then it's going to continue to be a problem. And that is our individual fault. It's not a system's fault.
Hello, and I wanted to make a point that with so much mixing of the race, you really can't put a person in one category.
So yes, genetic admixture does occur. However, there are certain traits that happen in populations that are associated with a racial and ethnic group that I think are very relevant. Kidney disease is one of them, right? It's prevalent and because of APO1 in African Americans. So in an algorithm to allocate a kidney transplant, which actually did happen, by the way, at first, when the algorithm was developed, it actually chose white women as the preference population for kidney transplant. Those are the people who needed it less, but it was based upon, part of the algorithm was based upon if you had donated a kidney in your lifetime, it raised your status to get a kidney. So white women were the population groups that have given away a kidney. So they actually rose to the top. However, when they redid the formula and took that factor into account, then it truly was African Americans that now raised to the top of a kidney transplant because of APO1 factor. So I get the prejudice, I get the discrimination. My father was an undocumented Mexican, I get it. But I'm also a researcher and a scientist, and I see the impact of not reporting race and ethnicity, because it ends up hurting every aspect of healthcare. And as long as we keep stigma and discrimination as part of the reasons, it's not going to ever get collected, and it's not going to ever get changed.
I'm curious if anybody, I think we all agree that we want to collect as much of this data as possible. Does anybody have kind of a framework or an approach for at the patient level, right? So, you know, 5th grade, 6th grade, region level, to justify why we need this data and how we're going to use it for their, you know, for the greater good. And Dr. Duran, feel free to jump in, but you know, I don't know that I have one. I'm not the one typically collecting this information.
Well, we've done a lot of studying on why minorities don't participate in clinical trials. And when we've tried to really look at why minorities don't participate, it was not necessarily because they feared discrimination, right? It was more because the physician and the researcher never asked them. So I think that some of the fears about discriminatory types of behaviors, like Tuskegee is often referred to, most African Americans under the age of 25 do not even know what Tuskegee is anymore. So those kinds of things don't exist as much as they used to 40 years ago or 30 years ago. So part of the problem with getting this kind of information or people of color involved is the physicians and the researchers aren't asking them to be involved because they think they're not going to be. But when they are, what worked was this information is not going to help you necessarily, but it will help your children and it will help other people's children in the future. And when it was approached in that way, there was almost 100% participation agreement.
It's funny that you brought that one up, because when COVID hit, everybody knew what Tuskegee Experiments was. And I had to explain to them, being a graduate of Tuskegee, they did not give the African American the syphilis, that they just didn't treat them to try to see the progression of disease. So I found myself being more of an advisor and trying to tell the community to why the vaccine and what is going on, as they did have the fears. So that fear is still there. I don't know where you looked at for that information, but the fear is definitely still there, and the doubts of research.
And thank you for being an advocate.
So are there any other opportunities we can think about from, I think we talked a little about traditional healthcare institutions. What about community health organizations in this space? Sounds like education's a big piece there. Any other takers?
I have a comment question. And I will start by saying I'm not a data person at all. I work in participant recruitment. So one of our tools is Informatics tools, and obviously, but I am not a data scientist like some of you on here. But I was curious, the conversation around other ways. I know we talked about capturing race, ethnicity, and how important it is, and kind of some of the things around it. But I was wondering about, and I apologize, I joined this group late, so maybe this was already discussed, the thoughts about other ways we can capture what they're experiencing that speak to their health just as much as their race and ethnicity. We know that certain populations, depending on where they live, their access to nutrition, health education, clean water, like there's so many different various factors. And so I was curious about building that into the, just like demographics we collecting those things that impact their health just as much. And any thoughts around that?
Well, those are your social determinants of health, right?
Yeah.
And so there was some discussion about how that's collected. And one of the things that I really suggested with that is that in your local areas, you really need to know, depending on also the disease and disorder, which social determinants of health make the most difference. So oftentimes when we run AI bias mitigation strategies, and different tools, oftentimes it's not race and ethnicity, it's poverty that makes a difference. So you're right, there are other sort of issues to that, but poverty also doesn't have the same impact as discrimination does on your race. So that's kind of teased out a little bit. So you really need to sort of know which social determinants of health are most impactful in your area, because it's too burdensome to catch everything.
Thank you. And adding to somebody asked before about ways to ask about certain questions explain it. We had an investigator once who, I'm from Oregon Health and Science University, in our community groups, who connected it to resources. And so when they were asking about it, it wasn't just, I want to take all this personal information from you, but they made sure to kind of have to also then be able to connect those people, like value added to resources. So it was also to the benefit of their study, but they also provided value back to these individuals as far as being able to connect them. Then like, thank you for letting us know this. And also here's some help along with that. So, which seemed to be a way that people felt more comfortable disclosing the information.
Yeah, I mean, that kind of approach we know sometimes works. I think the sort of, as we move into this world of AI and data science, I'm struggling with even this bigger issue, and you reminded me of it when you brought that up, is when anyone collects information, including your electronic health records, you have to consent. And you have to consent that they told you how this information would be used. In the AI world, when we have all this data, and now there's a data sharing policy that from the federal government that says data has to be shared everywhere. It has to be posted and available. How do we consent our communities to this unknown use of data?
Yeah.
Looks like we're breaking out, but thank you for that very interesting discussion. We'll see you guys in